Welcome back our fans. 1. Hypertension. Hypertension is persistently elevated systolic blood pressure, SBP, above 140 mm of mercury or diastolic blood pressure, DBP, above 90 mm of mercury. High normal BP. Individuals who could benefit from lifestyle interventions and who would receive pharmacological treatment if compelling indications are present. Grade 1 and Grade 2 hypertensio. Individuals should receive pharmacological treatment. General manifestations of hypertension. A. May remain asymptomatic for years. B. Early symptoms. 1. Headache. 2. Blurred vision. 3. Tinnitus. 4. Dizziness. 5. Fatigue. A. Complications. 1. Ventricular hypertrophy. 2. Stroke. 3. Arteriosclerosis. 4. Retinal damage. 5. Renal failure. B. Hypertensive emergency. Blood pressure exceeding 180/120 plus evidence of organ dysfunction as O. Intracerebral hemorrhage. O. Unstable angina pectoris. O. Acute myocardial infarction, or O. Heart failure. Clinical picture can be associated with O. Chest pain. O. Dyspnea. O. Change in mental status. O. Visual disturbance, or O. Neurologic deficit. Treatment. 1. Lifestyle changes, losing weight, low salt diet, stopping smoking and alcohol. 2. Antihypertensive medications, including diuretics, beta blockers, calcium channels blockers, angiotensin converting enzyme, ACE, inhibitors and vasodilators. Oral manifestations of hypertension. 1. Facial palsy. 2. Side effects of antihypertensives. 1. Xerostomia. 2. Salivary gland swelling. 1. Lichenoid reaction. 2. Erythema multiforme. 3. Angioedema. 4. Gingival hyperplasia. 2. Ride calcium channel blockers, nifedipine. Dental management of hypertension patient. 1. The dentist should spot an undiagnosed hypertensive patient through detailed history of symptoms, medications of hypertensive complications and routine BP measurement at the first dental visit. 2. Delaying dental treatment and referral in cases of A. Undiagnosed patient. B. BP above the patient's baseline, uncontrolled. C. BP above 180 mHg systolic or 100 mm Hg diastolic. If emergency dental condition, it should be managed pharmacologically until the patient is controlled. 3. Stress reduction protocol to avoid endogenous release of adrenaline and higher rise in BP. 4. Drug-induced orthostatic hypotension. So, rapid changes in chair position are avoided. 5. Bleeding is not commonly caused by hypertension, but by anticoagulants used by hypertension patients. 1. Use of epinephrine containing local anesthesia. Benefits. Delays systemic absorption. Increases the duration of anesthesia, and provides local hemostasis. So, profound local anesthesia critical for pain and anxiety control. Risks. Elevation in plasma epinephrine. Rise in BP and heart rate. Thus, the existing evidence indicates that the benefits of use of epinephrine outweigh the increased risks, so long as modest doses, 1 or 2 cartridges of 2% lidocaine with 100,000 epinephrine. But avoid O. Intravascular injection, use aspirating syringe. O. Levonorepinephrine due to excessive vasoconstriction. O. Topical vasoconstrictor use for local hemostasis. O. Epinephrine impregnated gingival retraction cords. 1. Drug interactions. A. Prolonged use of NSAIDs reduce the efficacy of antihypertensives. B. Erythromycin and clarithromycin increase the hypotensive action of calcium channel blockers. 1. Ischemic heart disease. Ischemic, coronary, heart disease occurs due to persistent reduction in the blood supply and oxygen supply to the heart through the coronaries. This reduction may be due to a thrombus obstructing the arteries, or thickening of the arterial walls and so narrowing of its lumens, atherosclerosis. Depending on the duration and extent of the ischemia, the heart will suffer from A. Angina pectoris, pain due to temporary low blood and oxygen supply to a certain part of the heart muscle, oxygen demands exceeding the supply. B. Myocardial infarction, MI, necrosis of the affected part of the heart muscle due to permanent loss of blood and oxygen supply. General manifestations of ischemic heart disease. 1. Chest pain. Angina. Stable. Recurring, unchanging pattern. Precipitated by exertion but also may occur with eating or stress. Relieved by cessation of the precipitating activity, by rest, or with the use of nitroglycerin. Unstable. Worsening pain with increasing severity, frequency, or duration. Or occurring at rest or during sleep. Not relieved by nitroglycerin. Myocardial infarction. Not relieved by rest, or with the use of nitroglycerin. Lasts longer than 15 minutes, greater than 20 minutes. Retrosternal chest pain. Aching, heavy, squeezing pressure or tightness. May radiate into the shoulder, left or right arm, neck, or lower jaw. 1. Palpitations, disagreeable awareness of the heartbeats. 2. Syncope, transient loss of consciousness, due to inadequate cerebral blood flow. 3. Complications. Heart failure. Retinal changes to RI to hypertension and DM. Medical management. 1. Treatment of risk factors for cardiovascular disease, hypertension. 2. Lifestyle modification, weight loss, exercise, smoking cessation. 3. Pharmacologic management, nitrates, beta blockers, calcium channel blockers, and antiplatelet agents. 4. Surgical management, stenting, coronary artery bypass grafting. Oral manifestations. 1. Coronary heart disease does not directly induce oral lesions. 2. In rare cases, cardiac pain is referred to the lower jaw, or teeth. The pattern of onset and relief of pain serves as a diagnostic clue. 3. Side effects of drugs include xerostomia, lichenoid reactions, angioedema, stomatitis, ulcers, gingival hyperplasia, increased bleeding due to antiplatelet drugs, aspirin.